All right, thank you. Um, Thank you all for waking up. I'm sure you all are super excited to learn about TXA at 6:30 in the morning. First of all, although I am a fan of Michigan, um, given that I trained there, I spent about an hour and a half trying to figure out how to get this off of the slide last night, and then I gave up. So that was not intentional, but I guess you will all get to see who I'm cheering for on Saturday. Um, I don't have any disclosures. She just kind of went through this in the bio. Um, if you ever have any questions about patients or ever need help with patients with infections, fractures, anything around joint replacements, I'm happy to help, and that's something I enjoy. So please reach out. And one fun fact about myself is that I worked on a commercial salmon fishing boat in Alaska right after I graduated high school. So today's presentation, we're going to go over hypothetical case, talk a little bit about blood transfusions, and then tranexamic acid. How does it work? Its use in joint replacements, and then other surgeries. The patient we're theoretically talking about, not that any of us have sick patients or anything, but we have a 75-year-old male undergoing a right anterior total hip. He has a history of AFib, stroke, MI, and coronary artery disease with a stent placement. And we usually walk into the OR at this time, and we try to get TXA used, and sometimes our anesthesia friends are not interested in giving it in some of these patients. And so the question always is to TXA or not, and how is it going to be given? And so in general, when we think about this stuff, it's kind of this balance that we have to think of. Obviously, we want to minimize blood loss, which can lead to ischemia and an eventual transfusion, but we also don't want to create a hypercoagulable state for the patient, which could lead to other more serious and sinister side effects or problems. So we've gone through a number of things that we now do for certain procedures to try to tip that balance in our favor. Some people use tourniquets, although those are sometimes going away with total knees. We try to get appropriate hypotension during the surgery. And I think another big one is actual surgical technique, the way that we perform the surgeries. Historically, there were a number of other options that people tended to use. Some of these are not as common anymore. So in general, blood transfusions we know are bad. They increase risk of infection, they increase mortality. And what I think is interesting is that in the mid 2000s, the transfusion rate for total joints was about 50%, which nowadays that's unheard of. And so I think there's been a lot of work in the last 15 years that have gone into this. Once we saw how bad these transfusions really were for patients, a lot of things changed. One of them being the liberal restrictive transfusion protocols. In terms of when do we transfuse, is that when a hemoglobin drops to 10, which is what it historically was, which is why a lot of people were getting packed red blood cells, or do we decrease it to 7, which was kind of where the cardiac literature was going. I think that's a big reason. That's probably the main thing that dropped the blood transfusion rate more than anything else, but including part of the drop was also TXA. And so we're going to talk a little bit about TXA, how it works. And I remember in medical school, we learned about a lot of drugs. Most of them I don't use in my practice. And so kind of have to go through that same process when I'm introducing a new drug into my practice, trying to figure out how does it work? When do we use it? When do we not? What are the side effects, and how much is it really costing? So in general, TXA has been around for over 50 or 60 years now, started by a woman, Utako Okamoto. Her and her husband developed this in Japan. It soon got on the list of the most effective and safe medicines needed in a health system by the World Health Organization. Its initial use was for heavy menstrual bleeding and tooth extractions in patients with bleeding disorders. And an interesting fact about it is that it's an over-the-counter drug in Japan and the United Kingdom. So it started coming to the US after there was a randomized controlled trial called the CRASH-2 study that randomized trauma patients, not orthopedic trauma, just trauma in general, into receiving TXA at that time of presentation to the ER versus not. And if they were transfused, or if they were transfused with TXA at that within 3 hours, it reduced mortality in these patients, and there was no increased risk of thrombosis. We didn't see the first ortho papers in America for at least until like the early to mid 2000s. And it started getting a lot of good press, including from here, this was a New York Times article, a cheap drug is found to save bleeding victims. So it kind of caught on pretty quick. So the important thing about this is that it is not a procoagulant. So that's where a lot of people get mixed up, is they think that it's going to cause a blood clot. It's not I'm going to show a picture, I apologize, but I'm going to show a picture of the coagulation cascade. I know we haven't looked at it in many years. All of us that went to med school had it memorized at one point. There's no memorization going to be happening. But I'll show you kind of where in that line it works. But the important part is it's an antifibrinolytic, meaning it stabilizes the blood clot that's already formed, but it does not clot. It does not cause blood clot. And really what TXA is it's lysine. It's a synthetic analog of lysine that can bind in somewhere in this, I'll show you where, but in this coagulation cascade to prevent it or to stabilize that clot. Also important is that it's renally excreted, and so you don't have to change any dose for hepatic disease, but you may need to decrease it or talk to pharmacy and people that have significant renal disease. So again, here I apologize for showing this at 6:30 in the morning, but in the bottom of the screen with the bright red star, you can see where TXA is actually acting. So it has nothing to do with the clotting cascade. And it has essentially the reverse effect of TPA. So TPA we use in strokes when people throw a clot and in their brain, and we're trying to break it down. So TPA breaks down, it breaks down that fibrin clot, whereas TXA will go in and stop the clot from breaking down. You can see here that black square is where TXA enters. That's where lysine normally enters, and it blocks the fibrin, TPA, and plasminogen from interacting and breaking down. So I show you all this because I have been told by many people they don't want to give it because they're scared that it's going to cause blood clot formation, but that is not how TXA works at all. So true on-label indications are very small. They're injectable and oral options, and really it's the same indications that it originally had at the time when it was created back in the 60s. Off-label, or we'll talk about that. I'm going to have this slide next, but off-label is used in a lot of things, and we'll talk about these in total joints and spine, liver, trauma, cardiac, and we'll talk about some other orthopedic procedures. There are rare side effects with this medication. Again, it's a lysine analog, so this is just a protein breakdown product. So it's not, it doesn't have too many allergic reactions, although they have been reported. No seizures have been reported in orthopedic literature, only cardiac literature. And the rest of these are all just common side effects that I don't know how you would be able to tell if it's a overdose of TXA, if someone has joint pain or muscle pain. I'm not sure how they figured all that out, but those are all what they say are the side effects. The only one that I find interesting in there is that people feel unusually happy if you have an overdose of TXA. So maybe it's not all bad. So contraindications. There's a short list of FDA contraindications. The first one being interesting is colored blindness, because an overdose of TXA can cause you to not be able to see color anymore. And so people that are colored blind to start with, they say you should have caution with this because they don't have that side effect, and that's one of the earlier side effects for people. So I don't change my practice if I have a patient that's colorblind. It's not something I'm asking my patients, but it's just something interesting and something to note. In patients with a subarachnoid hemorrhage, there are some case reports of people having cerebral edema that have led to some cerebral infarctions, and then just hypersensitivity to any TXA ingredients. We hear about a lot of other contraindications and when people don't want to give it, and so we'll talk about some of those in a bit. Another important thing, this picture of Mark Schleier, who's the president of the hospital at Mercy Gilbert and at Chandler Regional, but this slide will make him happy because TXA in general is cheap compared to a lot of the other drugs that we use. And this is a study from 2013, and I imagine it's showing that transfusion rates, when it decreased, they show that TXA itself helped decrease the transfusion rates from 21 to about 9%, which led to a savings of about almost $900. And I imagine that the price of a transfusion has only significantly increased, and although the number of transfusions has significantly decreased. So I'm guessing that price per patient for IV TXA has gone significantly down. So we know what it does, but does it work? So let's talk about it in some of the total joints literature. So these are some of the earlier studies looking at TXA. So in a total knee arthroplasty, there's a meta-analysis looking at our TXA given by IV for primary total knees. Total of 15 studies, 400 patients. It decreased blood loss by 504 milliliters and reduced the need for transfusion. And there was no difference in DVT and PE. And when I was first looking back at this study, I saw 504 milliliters. How are people losing that much in a total knee? But this is also at the time when people were still putting in drains in all of their primary total knees. And so they were recording it mostly via the estimated blood loss in surgery, as well as the drain, the amount that came out of the drain. So same with this study. This is by Zhu et al. Similar type of study, meta-analysis of randomized controlled trials and total hip. 19 studies with a total of 168 patients. This wasn't very many, but there were a lot of studies happening, and a number of much larger studies have happened since then. And this decreased total blood loss by 305 milliliters and reduced the transfusion rate again. How do you give it? Every paper has a different option of how to give it. Can you give it IV? Should you give it topical? Some people are putting it, reversing it and putting it through a drain. You can give it oral. And it turns out all of them there have been a number of trials where they've looked at them and put them all head to head, and they are all pretty much the same. So I prefer, IV because it's easiest and it doesn't stop my workflow while I'm doing surgery. And I think that's the most reliable in terms of getting it where we need to get it for sure. And so I typically use a gram at the beginning and a gram at the end. If I'm doing a total knee replacement, I make sure I put it up before the tourniquet goes up, and I give the second dose after the tourniquet's gone down to make sure that I'm actually getting it to the site where I need it. In 2016, this is probably one of the more landmark studies that came out that started changing some people's minds about it, but this was a big registry. The Michigan Arthroplasty Registry is one of my mentors from residency, but they looked at approximately 34,000 joints and looked back retrospectively to see what the difference was. And it turned out in the knee literature, when you were looking at 35,000 patients across multiple hospitals, hundreds of surgeons, across the board, it dropped hemoglobin, or it led to a decreased drop in hemoglobin, decreased blood transfusions, decreased VTE events, and no change in cardiovascular events between the two. And so I think that's important. Not only did it not cause more VTE events, it actually decreased the number of VTE events. So a lot of times we're told, oh, we don't want to cause a DVT or a PE because they're at high risk for that. This literature is showing that it decreases it in knees. Didn't have as big of an effect in hips, but still similar in terms of decrease in hemoglobin, drop in blood transfusions. There was no association between TXA and increased risk of MI, stroke, TIA, or DVT or PE. In a critique of the paper and a commentary of the paper, more or less they said that this paper has finally put to rest these concerns and to allow for antifibrinolytics to become the standard of care in total joint arthroplasty. And I think at this point it has been. I don't know many joint surgeons that are no longer using it. Then the question comes in, all right, what about high-risk patients? So AUKUS came out with a statement back in 2018 that said, well, we don't have they gave strong recommendations for pretty much everything, except they gave a moderate recommendation for its use in high-risk patients. And so in 2020, this group out of the Mayo Clinic, mostly anesthesiologists, they did a retrospective study of 38,000 patients who had surgery across the Mayo Clinic's hospitals. And they looked at people with DVTs, PEs, with a history of, not at the time, but with a history of DVT, PE, MIs, CVAs, AFib, A-flutter, coronary artery bypass with a graft. These are all excuses that I'm always told we cannot give it because this patient has one of these things. And so they found patients and they deemed them high risk if they had one of those in their past medical history. And they looked at the people who had those problems and those who got TXA and who did not. And it turns out that within that high risk group, people that got TXA actually had lower risks of DVT, PE, MI, CVA. And that same thing happened in both the high risk and the low risk group. And so this paper came out trying to show our own, not academy, but to show AUKUS and add to that argument that this is a medication that does not cause these problems, but that does actually help prevent them. And in here, in the conclusion of that study, it said we present incremental evidence to support TXA administration for high-risk patients undergoing primary arthroplasties. Okay, I know you're all, I can geek out on joints stuff all the time, but I try to go and look at some other non-joints literature. It hurt me to do it, but I wanted to make sure this was appealing to a broad audience. And so I was looking at it, what about for our trauma friends that are on this presentation? So looking at femoral neck fractures, so hip fractures in general, that same group out of Mayo figured out that they got a decent paper out of that and said, hey, let's try to go do that using our same criteria. Let's look at femoral neck fractures and let's look at intertrope fractures. And so they use the same high risk versus low risk. Turns out that someone, even if they're at high risk and they undergo a arthroplasty for a hip fracture or a cephalomedullary nail for an intertrochanteric femur fracture, then they both have decreased rates of all of those same things that the last paper showed. And so it's something that I am now using when I'm on call and doing hip fractures. I try to use it in all of my hip fracture cases as well. Similar evidence has come out to support it in pelvis and acetabular fractures, showing this was a randomized controlled study that showed decreased transfusion rates in the TXA group versus non-TXA group in patients with both acetabular fractures and pelvic fractures. And so, I'm sorry, this was not an RCT. This was a systematic review and meta-analysis of RCTs. For my sports friends that are on the call, it's now becoming more widespread in its use in the sports medicine world. So in ACL reconstruction, there are a number of papers. There's probably as many papers coming out in the sports with TXA as anything else. And so it's now heavily used in ACL reconstruction. This was a recent AJSM publication. It was another systematic review looking at 5 randomized controlled trials. They gave it different ways. 3 of them gave IV tranexamic acid, 2 gave it as an intra-articular injection, and 1 had a little bit of both. Overall, it reduced the rates of hemarthrosis and need for aspiration after surgery, improved Lisham scores, had improved VAS scores both immediately post-op as well as 6-week post-op, had improved range of motion, and there was no difference in DVT. So I mean, those are all the things that you're, as a sports surgeon, you're working on and trying to, help your patient get range of motion and not have a DVT and decrease pain. And this is showing this is a cheap medication that we can use in the OR to help us accomplish that. Total shoulders and reverse total shoulders, recent, again, meta-analysis here, done a couple of years ago, similar effects with in terms of drop in hemoglobin, total blood loss and transfusion rates. And then for my foot and ankle friends, the study on the left, tranexamic acid utilization in foot and ankle surgery. So they just kind of said overall, in general, with what they labeled foot and ankle surgeries, it did show a decreased estimated blood loss, but it did not change transfusion rates, given that there's not much blood loss there in most of the foot and ankle surgeries. And then they've also looked at it in total ankle replacements, and it's also showing and trending in the same direction. And so, as you can tell, I am a big fan of this medication. I think it's transformed joint replacement surgery and helps significantly patients get, decreased transfusions and has improved complications. There are new papers coming out, and I didn't want to put them all in here, but showing that it actually can decrease infection rates, which makes sense because we know infections go up with transfusion and with more blood loss, especially if it gets stuck in the joint that we had just operated on. So, but a lot of new evidence coming out showing it can significantly decrease infection rates too. So these are my these are the papers that I was using for the today, and this is my daughter pointing out that you too should be using TXA in your surgery.